Well, the title is New Treatments in Psoriatic Arthritis. And I have to say that I was asking myself how to organize this presentation, since, in fact, we have new treatments and we also have new data with the old treatments. And you will see there's a story flow in here, starting of where we come from and why we need new treatments. And I will also present a little bit of the recommendations that we have now in Europe, the Euro recommendations, which are newer, and give you a little bit of an evidence of why these recommendations have been put together as they have done so. We'd like to remind you that when we talk about spondyloarthritis, and we also when we talk about spondyloarthritis, axial or maybe peripheral diseases such as psoriatic arthritis, the information that we have is based on the studies that we have been trying drugs on. So we go really from the bedside to back to bench and understand how cytokines work. Why do I say that? For example, because one could say that, well, for example, for axial spondyloarthritis, CRP is important. IL-6 is a clear competitor of CRP. Giving IL-6 inhibitors would work in axial spondyloarthritis or even psoriatic arthritis. This doesn't apply. So obviously, we do have a kind of an overview, and we try to understand not only the new treatments that we can apply on psoriatic arthritis, but we also can try to understand whether or not these treatments would work in other parts of spondyloarthritis, such as the axial disease. That's a very, let's say, general introduction I would like to make here, and you will see the data of those treatments in a second. Please also remember that at the moment, at least, we believe that IL-23 with or without IL-12, you remember there's also drugs on that, obviously, it may be playing a central role to the pathogenesis of psoriasis. And we also know that psoriasis in the vast majority of the patients does go over from the skin and the nail involvement to the joints and may cause psoriatic arthritis. So overall, indeed, we believe that the inflammatory cascade starts there, IL-23, that's on the very left side. And then we will move over to the right side of the cascade. The right side of the cascade would be inflammatory cascade would mean that after secretion of IL-23, that after the response of the body, the innate inflammatory response will lead via different progenitor cells to the secretion of IL-17 and of TNF. And therefore, and this is again all because of the drug treatments that we have understood that better. Therefore, we would then see the inflammation. So again, we have the site of inflammatory of the activity, we have the trigger, we activate the inflammatory cascade by the IL-23, and thereafter IL-17 and TNF come into play. So that's the story that we believe is happening at the moment. And of course, the different cytokine blockers that we give are obviously applying in exactly this story flow. Remember, the reason to develop psoriatic arthritis obviously is on the skin, and we do know that mechanical stress may lead to what we call the deep Koebner phenomenon. Here you see that on the skin. I'm pretty sure you've heard about that. I'm not going into all the details here. I would just like to remind you again, we start in the skin and then we go inside and into the joint. And for example, one part of that story would be that, or could be that indeed trauma as a trigger, a simple trauma as a trigger, would lead to an increased inflammatory activity of the bone in patients with psoriasis. Both the bone and the joints, but not the nerves and the skin would be affected. So this is in fact the explanation or the confirmation of that deep Koebner phenomenon that I mentioned before. You see that here, the physical trauma would be one of those reasons. One other thing, and I really like the way they thought about this in this publication, one other thing is mechanical stress. So what they did in this study was to take patients who were what they called smartphone addicted, and they checked the hand joints of those smartphone addicted patients to psoriatic patients based on ultrasound. And they found that if you are SA, if you are smartphone addicted, as compared to no addiction to smartphones, there you are more likely in psoriasis to develop psoriatic arthritis as compared to if you are not psoriasis patient, as compared to if you have no addiction to the smartphone. So on the basis of psoriasis, mechanical stress may lead to arthritic disease. And this is independent of whether or not this is the right hand or the left hand. You see here the green bars are those with psoriasis and smartphone addiction, and those were the one who developed psoriatic arthritis. So overall, mechanical stress or trauma are obviously of importance. Of course, we can also try to explain all this by genetic studies. I have to say that the new treatments that we are talking about, or we will be talking about here, and I'm not a geneticist, so I cannot explain everything on that. I can understand what they did here, but the clear explanation of how to influence that, I think nobody really knows exactly, because all the treatments that we have, again, they actually act on the cytokine level and not on the genetic level yet. Maybe we're changing the epigenetic situation, but we need to understand that better, this kind of process. Nevertheless, you need to remember that we do have different differences, but also similar areas where psoriasis and psoriatic arthritis have in common. And that's something that obviously may also mediate the secretion of cytokines, as you see in this slide. Now I come back to where I came from in the beginning, and the question is, how does that now work in terms of treatment? I'm pretty sure you all know this study, which was pivotal in understanding the role of IL-23, IL-17, and thereafter TNF secretion in patients with, or in animals with, or in specimens with psoriasis or psoriatic arthritis. And what they found was that exactly in those enthesial areas, IL-23 would be has worked as a booster of IL-17, as compared to those specimens where they were not fed with IL-23. These were the controls, and IL-17 was not secreted so much. And where IL-17 was blocked as compared to the isotype form, this means these animals here were not triggered to develop the disease. Blocking IL-17 indeed improved both enthesitis extent and enthesitis severity. So the area that was covered and also the severity, the swelling, that was also there, it decreased significantly after blocking IL-17. Again, the IL-17 that comes from IL-23 may end up to TNF. And that's in fact what I was just discussing. Again, there is a trigger, biomechanical stress, H1127 as the genetic trigger here, all the microbiome triggering and inflammation, secreting IL-23, going over to the enthesial part and the T cell, which then involves IL-17 and TNF as the end product. So that's the story. That's what's happening. Now, if we have treatments, again, we can apply them for treating based on the different parts of this inflammation that we are looking at. I am well aware that this might be a little bit too complicated by really talking about IL-23 inhibition, IL-6, IL-1, JAK inhibition. You see all the players here, IL-12, for example, PD4 inhibition, IL-17, again, TNF. Still, we are acting in a very small part of the disease, simply because obviously, let's say, get an example, IL-17 may also be boosted by either A or F by other factors than IL-23 alone. Or TNF may also come in and play a different role as the one that we think there is. So we still are very limited in our way of thinking and understanding the disease. And you see that I take much more time to explain this in this presentation as compared to axial spondyloarthritis, because I believe that psoriatic arthritis may be even a little bit more complicated to capture, because you have psoriasis and arthritis together. But again, remember, what we do know is that the psoriasis may lead to all these cytokines. That's a little bit of a duplication of what I said before. Nevertheless, the psoriatic skin is already, in fact, the damaged skin is like the bone that now has erosions, as compared to the pre-psoriatic skin, which may also secrete those cytokines. But of course, we don't know who is the patient who will develop psoriasis later on. Now, I put this in because I find it pretty interesting to to kind of summarize what I've said, and without wanting to, repeat myself many times, remember we do have the different drugs, and those different drugs, there are many. There's some of them which are there already in psoriatic arthritis, some of them which are now about to come, but they are already indicated for psoriasis. All of them have the target cell, which is a keratinocyte, to be honest with you. And this may indeed directly or indirectly then influence the osteoclastic precursor cell. That's the way this whole pattern works. And I come back to that here. Obviously, something is happening already pre-psoriatic skin. You remember, you get the trigger, and thereafter this whole thing is starting, the whole process. And then we have the enthesophyte, the new bone formation, of course, including also sometimes erosions because of the chronic inflammation. Now, so PSA and psoriasis, are they nevertheless such a disease that we can say that they do have many things in common or not? Well, I think either this slide or this one here does answer that question. Yes, they do have many things in common, but they are not entirely the same disease, simply because some of the patients with psoriasis will not develop psoriatic arthritis, and also a smaller proportion, though, patients with psoriatic arthritis or the typical pattern of psoriatic arthritis just don't have psoriasis. Yeah. So there is things that are still unexplored in terms of understanding exactly where this, where the common things in and where not. That might also play a role for the treatment decision, because there are drugs that work better in psoriasis than psoriatic arthritis and vice versa. And these drugs, they have developed over time. So we do know that, of course, we started very early, and in the break even, which is the year 2000, more or less, we had more and more biologics or non-biologic targeted synthetic dimers, for example, coming into the market, coming into our life, including, of course, also biosimilars. And of course, we may also have other drugs coming in. Oparazitinib has already been approved. At least this is the situation for Germany. So the future is really pretty bright in this disease. And what we also do know is that we need to adapt our treatment based on the compounds, based on what they do, but also based on the more complex situation that we have in psoriatic arthritis, which is the different domains. Especially peripheral arthritis, enthesitis, and dactylitis is what we are most interested in because we know more about it. I will speak a little bit later also about the axial disease, skin and nails. I don't know if we have dermatologists among you in the audience, but I'm pretty happy to also hear what you think about everything that I just said before in terms of whether or not you would be treating someone with severe skin or nail involvement and a little bit of peripheral arthritis as compared to someone who has more peripheral arthritis. These are the things that we all don't know very much or very well in daily practice how to deal with. I would like to also remind you that as time goes by, and well, these are the GRAPPA recommendations from 2016. As time goes by, the societies that we are looking at, the big societies such as not only GRAPPA but also the ACR, they obviously adapt their treatment strategies accordingly. I'm not such a big fan of the ACR recommendations, I have to say, because although they have incorporated all of those drugs that I mentioned before, what I am missing here, and that's now the thing about the new drugs that my title of the presentation is saying, the new drugs are there, but we also need to know how to apply them, how to use them. What they do is, and that's part number one, that's step number one. They say that if you have a patient with active PSA, you can do whatever you want. At least that's the way I read these recommendations. You can start with a TNF blocker, or start with a small molecule over an IL-17 inhibitor, or start with a Trexate, or start with an IL-17 inhibitor. And then if the PSA is still active, then we go over to other drugs such as, again, TNF blockers, more small molecules, or methotrexate. And if that is not happening, again, active PSA, despite the small molecule, then you would switch to another one. So in fact, at least to my understanding of the disease, it doesn't really give, and the same is, by the way, true here, it doesn't really give me a clear guidance. I do believe that we've been able, with the EULAR recommendations now, to improve a little bit the situation. I've taken that from the oral presentation, but these data are out already. Again, I'm not here because I'm not talking about this because I'm biased, also being part of the committee, but because I believe that the more we learn as time goes by, the better we can really sort out where to put which treatment. The background of our recommendations at EULAR, and in fact, the background of everything that is coming here after, and then you may also be aware that the GRAPPA recommendations are also being revisited at the moment, is that we do have many different drug classes, such as TNF inhibitors that we had before, but also IL-17 inhibitors and IL-12/23 inhibitors, which are now very well established in the treatment of PSA. And therefore, we really put them in the upper scale, in the upper part, as compared to the drugs that are coming in now and may have a little bit of a, let's say, lesser good evidence. I will show you the data, how they are put together in the recommendations. Well, this is a slide that, again, I took the oral presentation that we gave, obviously showing also how the recommendations are expanding. From 10, we came up to 12 recommendations. From 5, we came up to 6 overarching principles. What is new? First of all, we have the new overarching principle that when we do manage patients with psoriatic arthritis as rheumatologists, we would also consider not only musculoskeletal manifestations, but the single musculoskeletal manifestations. This means not only the peripheral, but also the axial, not only the poly, but also the oligoarticular disease. These are things that we now are taking into account in addition, because we have drugs that we would address these questions about. Just as a reminder here, we also have the levels of evidence, meaning the level 1, high quality RCTs, level 5, let's say anecdotal evidence, and foundational evidence, as you see here. Well, it's important to remember that I will also be showing you the level of evidence in these recommendations so that you remember where this comes from, what it exactly means. And I will also be showing you the strength of these recommendations in grading, grade A, B, and C. This means A, very high, and C, lower strength of recommendations. This means consensus, but not quality patient-oriented evidence. Now, well, I will not go through all the recommendations. Don't be afraid about that. I will try to really give you the most important ones, saying that the treat to target and the initial treatment proposal for flow disease activity is being maintained. We're reaching for remission. I showed you what remission is in psoriatic arthritis before, how we also measure it, for example, by BASTA or MDA. And if this is not possible, then we would aim for low disease activity. We would start with an NSAID sometimes just for a symptom relief. And we also do, we do also recommend local injections of glucocorticoids if treatment needs support. This means here adjunctive treatment in patients with arthritis. One other thing that we've also improved, and this is indeed the new treatments now, was also asked for this presentation should be showing, we have changed things. And I mentioned that in the beginning, where we say, well, peripheral disease is not just peripheral disease. It may be that you have poly or oligoarthritic involvement, and also the enthesial disease and the predominant axial disease may be taken into consideration. So we really go into more details here, also on the EULAR level, not actually, or even coming closer to the GRAPPA recommendations as they have been published before. We start as a first-line DMARD with a conventional synthetic DMARD. In patients with polyarthritis, a CS DMARD should be initiated rapidly. In patients with mono or oligoarthritis, particularly, and that's something that some people don't really, let's say, agree with, but we believe that it was important because we're talking about the predictors also, particularly with those with poor predictive factors. What are the poor predictive factors? Well, these are the structural damage, which has occurred already, high CRP or ESR, dactylitis or nail involvement. Then a conventional synthetic DMARD should be considered. This means should be considered for sure. And thereafter, we would go over pretty rapidly to escalate the treatment. Now, remember, conventional synthetic DMARD, what is the evidence? We have methotrexate, which in fact didn't really show in that study, in the MIPA study, such a huge difference as compared to placebo, simply because also placebo patients responded very well. Only the PSARC improved significantly. ACR 20 or DAS 2080 was not significantly improved by methotrexate, but In that study, we have to acknowledge that the target dose was very low. And in fact, the study also took very long to recruit. So obviously, also the population may not have been the one that I or you may see in daily practice. We still support methotrexate in psoriatic arthritis as a starting point. We also know it has benefits, for example, for cardiac events and so on. And therefore, I believe it is sufficient to say that this is the first drug, together or shortly after non-steroidals. We also know that looking at oligo and polyarthritis, it does work in both, but also especially in polyarthritis, it works very well. So it's not a very soft drug. It does have a good effect in patients with psoriatic arthritis. And after 12 weeks, we do not only see the ACR outcomes as shown in the study from Leeds, it also resolves dactylitis and enthesitis. There is also leflunomide or other conventional synthetic DMARDs. You may remember that study from 2004 from the German group. Also here, there was an effect as compared to placebo. However, of course, the problem is the adverse events of that drug. I have to say that in our daily practice, we use it really very rarely. We also don't have so many patients anymore on leflunomide. We'd rather work with a combination of methotrexate and NSAIDs rather than giving it. Although sometimes with a very severe joint disease, we may indeed use it as well. Now, going over, we said that, of course, if you fail conventional DMARD, you would go over to a biologic DMARD. And now, at least for the EULAR recommendations, those three pathways or those three modes of action, TNF inhibitors, IL-17 inhibitors, 12, 23, or 23 inhibitors, are on the same level. We don't really do any kind of differences here. Again, usually a biologic DMARD after CS DMARD, especially if the main feature is peripheral arthritis. That's in fact what's in this blue box shown in the title. Interestingly, when there is relevant skin involvement in a PSA patient, we believe that IL-17 or IL-12/23 inhibitors may be preferred because of their extremely good effects on skin. TNF blockers also work very well on skin, but we believe that the data show that those data are even better. Those drugs are even better. So overall, based on the systematic literature review, that's a proposal after conventional synthetic DMARD, including IL-23 here. This box should be a little bit lower. And we also have data for JAK inhibitors. At that time, when we conducted the survey, only tofacitinib data were there. Now we also have the upadacitinib data. And also PDE4 inhibitors may be used. I will show you where IL-23 inhibitors are also there. And again, without going into all the details here, and for whatever reason, this slide is a little bit cramped, we do know that especially the first three have a very good effect on all the domains that I mentioned for psoriatic arthritis being relevant. Now, what I do like in psoriatic arthritis very much is that they have those studies where they have head-to-head trials. And we don't have that in axial spondyloarthritis, unfortunately, at least not yet. In the SPIRIT head-to-head, ixekizumab was compared to adalimumab, and in the EXCEED trial, secukinumab was compared to adalimumab. What you see here is that here they took ACR 50, here they took ACR 20. No big differences were found when it came to those mainly musculoskeletal scores. So obviously there was not a very big difference in the outcomes, and similar was also found in the 52-week analysis of secukinumab versus adalimumab based on the sensitivity analysis overall. However, what they did find, and that's why the recommendations are as such, this is again ACR 50, there was a significant improvement, significant difference between patients who were treated with secukinumab in blue as compared to those with adalimumab, those are the IL-17 inhibitor versus the TNF inhibitor, in the skin response. Again, I bring it back to the point where I said, especially in those with severe skin response, IL-17 or IL-23 would be preferred. And this is one piece of evidence to support this data. IL-23 inhibition, this is shown here. I know it's a little bit small, especially if you look at the smaller smaller monitor. Nevertheless, what this data tell us is that patients with psoriatic arthritis for ACR20, they do also excellently respond to IL-23 inhibition. And this obviously may not be related to the pre-treatment with a biologic, with a TNF blocker. So patients with pre-treatment and those without pre-treatment, they reported similarly well. For the IL-12/23 inhibition specifically, there's also this study that was published from the German group, where they found that ustekinumab, as compared to a TNF blocker, was superior, not so much for the arthritis, but for the overall psoriatic arthritis, psoriasis outcome. This is here PASI, and for the enthesitis. So also therefore the recommendations were put together as such, as I showed you before. What I find interesting is data like these ones, where what they did was to give an IL-23 inhibitor to an IL-12/23 inhibitor and see what happens to the IL-17 levels. This means you give drugs which are similar, not the same, and you see what happened here. The two drugs are in purple and in blue. There was no difference in CRP improvement. So both of them, 12/23 inhibition and 23 inhibition alone, they work similarly well on the inflammatory activity by CRP. But the IL-23 inhibitor was better in decreasing IL-17 levels as the combined 12/23 inhibitor. Is it because IL-23 is more precise? Well, maybe. I showed you the theory before, 23/17 TNF. At least based on this data, there seems to be indeed an effect on IL-23 directly, which indirectly also influences the subsequent cytokines such as IL-17. We also discussed the place of JAK inhibitors in these recommendations, and we said that in patients with peripheral arthritis and those who do not respond well to CS DMARDs or at least one BDMARD, then we would consider a JAK inhibitor. I have to say that we use JAK inhibitors a lot in our daily practice, at least based on the recommendations and the study data from the literature review that were considered there. JAK inhibitor was not there yet to compete directly with biologic DMARDs, of course, and we know that situations have changed over time. Now, how did they change? Well, the data from the SELECT PSA studies have shown that indeed, at least for the lower outcomes, this means ACR20, upadacitinib may be, at least numerically, be even better than a TNF inhibitor. And for ACR50 and ACR70, the data are similar. This is the upadacitinib 15 milligrams dose, which is approved. That's a TNF blocker here. So again, you see how fast time may go by and how fast the field may develop. When it comes to new treatments, indeed, I believe that we are actually pretty equal with all of our treatments. This means biologic DMARDs and also JAK inhibitors. What about the place of apremilast? Here, at least based on the EULAR recommendations, we believe that unfortunately this drug is obviously very safe, but not as potent as the others when it comes to the treatment effect. So in patients, we said, with mild disease and where either you don't have a CS DMARD effect or you have a contraindication for a biologic DMARD or a JAK inhibitor, then we would consider PDE4 inhibitors. How do the data look like? Well, the bars here go up, but remember the scale doesn't go up that much. This means, at least when it comes to the ACR outcomes, we have lower numbers. Enthesitis improvement and resolution is also very low. This goes up to 25% as compared to the others, which really go up to 70 or 80%, the biologic DMARDs or JAK inhibitors. Therefore, again, this drug, again, although a blockbuster may be in the US because of the safety, we believe that the effect is not as good as the others. We also have the Astrea trial with abatacept in psoriatic arthritis. Well, I don't know if you're using it. We do not use it in psoriatic arthritis, obviously, because especially when it comes to the resolution of inflammatory activity, this means the swelling, the dactylitis, then we may have seen data, but they are not as good as the others, especially they do not really work as fast. These are not very bad data, but we believe that the place of abatacept is certainly much, much lower as compared to all the other treatments so far. What about switching of the drugs? You remember I also discussed that in the axial spondyloarthritis presentation. Well, we would switching means, I discussed it in the beginning of that, switching means we would switch in patients who are not really responding adequately to a biologic DMARD, either to another class or in the same class based on what the preference in a single situation of the patient is. And what about tapering? This I discussed indeed a little bit in more detail before. There we also consider tapering, but obviously cautious tapering, really slowly going on. One thing that I also would like to mention here is that we also have evidence about the axial disease, about the axial symptoms now in psoriatic arthritis. And it has become evident also in the corona data that patients with psoriatic arthritis may have axial disease, which is silent. This means they do not really feel it that much, or they do not complain that much when they come to the doctor, simply because they think they come for the psoriatic arthritis symptoms. But we need to ask them, because based on this data from the US, 1 out of 4 patients with psoriatic arthritis may also have axial disease. What are the data for treatment there? Well, we just published the data of the Maximize trial with secukinumab in patients with psoriatic arthritis and axial disease. Here you see the patients on active drug. Here you see the patients on placebo. Active drug means either 300 or 150 milligrams. And when these patients switched then to the active treatment, they also improved similarly. And they ended up, for example, here as 20 with more than 80% partly being positive, showing positive response, which again means that also that part of psoriatic arthritis can be indeed included in the treatment considerations that we have. Not only the clinical parts of the axial PSA, but also the MRI part here for the spine and here for the sacroiliac joints improved significantly. In those patients on placebo, they only improved when we switched to the active drug. This is week 12. This is week 52. That's the switch of the patients. And again, both spine and sacroiliac joints improved significantly. And we've seen, I wouldn't call them similar data, but we've seen data which point towards the same direction also with the IL-23 inhibition with guselkumab, where those patients who were considered positive for axial disease, when we evaluated the BASTAI, the spinal pain, the modified BASTAI without the peripheral question, or the ASTA-CRP, also here there was significant improvement as compared to the patients with placebo at week 24. Unfortunately, IL-23 itself does not work in axial spondyloarthritis. This means in established ankylosing spondylitis. These data are different from those data in psoriatic arthritis and axial disease, which brings me also to the point that axial PSA or PSA with axial symptoms may be different as compared to ankylosing spondylitis alone. Therefore, again, remember, we go from bench back to bench. IL-23 doesn't work in ankylosing spondylitis. So that's the summary of the recommendations for psoriatic arthritis. Again, we start with the clinical diagnosis. We check for poly or mono or oligoarthritis. We check for ecdysitis and predominantly axial disease. We go over to the NSAIDs and local injections, and thereafter we indeed go over to the conventional synthetic DMARDs for the peripheral disease, or otherwise for the axial disease, we would go over to the biologic DMARD with a TNF blocker or IL-17 inhibitor. That's a little bit old school nowadays, with the usual practice of starting with a TNF blocker is not really applicable that much anymore. For the axial patients, for the peripheral patient, again, we would start with any of the biologics, and thereafter we would switch within the classes. So how can we decide and select the treatments for PSA? This is a very, let's say, artificial maybe, or our opinion, selection, but well, we know that TNF blockers have the longest data. They work well in all 6 domains. They are moderate in skin, but they also cover uveitis and IBD. 12-23 inhibitors, very good in skin, very good also in IBD, inflammatory bowel disease. They have less frequent injections. That's for the patients who have phobia against needles. IL-17 inhibitors, they do not work in IBD, but they also cover all 6 domains, and they also are very good in moderate to severe skin disease. IL-23 also for skin disease, but not in axial disease, at least at that point in time where we conducted the recommendations. Now we don't know that this may not entirely hold true. There is a study now planned for axial disease as well, and JAK inhibitors, they are oral. That's certainly a benefit. They have a moderate effect on skin, but they still cover all 6 domains. We don't know exactly what they do in IBD, and they have no symptoms, for example, with the itching of the injection. So this will be the last slide. Thanks again, and I'm happy to take up questions.